Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. In this video, we will explain principles of prophylaxis against metastatic infection. Metastatic infection defined as the infection that occurs at a physically separate from the portal of entry of bacteria. Example is bacterial endocarditis. Metastatic infection refers to infection that occur in distant sites, not directly connected to the site of origin of the infection. And metastatic infections most commonly occur via a hematogenous route. As such, prophylactic administration of antibiotics has been used in various scenarios prior to dental treatment to minimize bacteria and therefore the incidence of metastatic infections. Sites that are considered most susceptible to the metastatic spread of infection include the heart valves and prosthetic joints. Infections of the heart valve results in infective endocarditis, whereas infection of prosthetic joints leads to the prosthetic failure. For metastatic infection to occur, several conditions must be met. The first and most important is a susceptible location in which an infection can be established. An example of this is the deformed heart valve with its altered endothelial surface onto which an irregularly surface vegetation is formed. Second factor is bacterial seeding of the susceptible area. So the bacterial seeding of the susceptible area must also take place. This seeding occurs as the result of the bacteremia, in which the bacteria from the mouth are carried to the susceptible site. Most likely, a quantitative factor is involved in this seeding process because the body experiences multiple episodes of small bacteremias as a result of normal daily activities such as chewing and toothbrushing. Turbulent blood flow across the deformed heart valve can traumatize the endothelial lining of the valve, which can then precipitate the deposition of platelets and fibrin, resulting in non-bacterial thrombotic endocarditis. Subsequently, bacterial proteins called adhesins recognize the fibrin and platelet matrix of non-bacterial thrombotic endocarditis. Some staphylococci and oral streptococci have these adhesins, which explain their association with infective endocarditis. Also necessary for the establishment of the metastatic infection is some impairment of local defenses. Once bacteria have attached to non-bacterial thrombotic endocarditis, they are protected from white blood cell phagocytosis by a thin coating of fibrin and an extracellular matrix synthesized by the bacteria, resulting in a biofilm. More than 90% of bacteria existing within the mature cardiac vegetations are in a metabolically inactive state, which also make them less susceptible to bactericidal antibiotics. Bacteria inhabiting such a biofilm coating on foreign bodies, such as prosthetic joint or dental implants, are not easily phagocytized by white blood cells or killed by antibiotics, as in endocarditis. Substantial evidence exists that questions the effectiveness of prophylactic antibiotics for infective subacute bacterial endocarditis when a patient undergoes invasive dental treatment, including oral surgery. The current rationale for the prophylactic antibiotic administration for infective endocarditis is based on the fact that infective endocarditis has significant morbidity and mortality. As with any intervention, the benefits and risks must be carefully weighed. In case of prophylaxis against infective endocarditis, the benefits of preventing severe morbidity and mortality in the select group of at-risk patients are deemed to outweigh the risks of adverse reactions to antibiotics discussed previously. This is in contrast to routine antibiotic prophylaxis for wound infection, where the benefits of preventing frequent minor, easily treated infections in a very large population are thought to not justify the risks of the adverse antibiotic reaction and high cost. In this light, indications for infective endocarditis prophylaxis have consistently narrowed regarding the formal recommendations by the American Heart Association. The latest recommendations appeared in 2017, jointly established with American College of Cardiology, shown in this table. It is mandatory that every dentist stay up to date on the current recommendations as well as future evidence-based updates as they become available. Prophylaxis against infective endocarditis is recommended before dental procedures that involve manipulation of gingival tissue, manipulation of the periapical region of the teeth, perforation of the oral mucosa. Commonly used pre-operative antibiotics regimens are listed in this table. It must also be stressed that non-antibiotic prophylactic measures should be rigorously implemented in the at-risk patient groups. Maintaining optimal oral hygiene should be the main goal in preventing infective endocarditis, as bacteremia not only occur during invasive dental procedures, but also during repeated everyday activities such as chewing, toothbrushing, and flossing. Also, prior to and during invasive dental procedures, surgical asepsis such as chlorhexidine gluconate rinses before the procedure and careful surgical technique should be employed. Some special situations warrant consideration of intra or post-operative antibiotics for infective endocarditis prevention. Examples include an at-risk patient whose specific condition was not disclosed until after initiating the dental procedure, or at-risk patient with unexpected bleeding during an otherwise minimally invasive dental procedure. In such cases, antibiotics should be administered as soon as possible, not later than 4 hours after observed bleeding, using the same dosages as for standard infective subacute bacterial endocarditis prophylaxis. Lastly, the clinician must understand that the infective endocarditis may still occur despite appropriate practice and strict adherence to the American Heart Association recommendation, and it is important to fully inform at-risk patients of this possibility. Dental procedures in which prophylaxis is not recommended are listed in this table. Antibiotic prophylaxis for metastatic infection before invasive dental procedure is also recommended for patients who receive chronic renal dialysis. Renal dialysis often requires a surgically created arteriovenous shunt in the forearm, and these shunts could be susceptible to metastatic infection due to turbulent flow. The same is true for ventriculoatrial shunts in patients with hydrocephaly. These shunts created for intracranial decompression could also be susceptible to metastatic infection. When encountering such patients, the dentist should communicate with the patient's physician, that is nephrologist for the dialysis patient or neurosurgeon for the hydrocephaly patient, to determine a plan appropriate for the specific patient. Now, prophylaxis is not recommended in patients with some cardiovascular conditions. These include coronary artery bypass CABG, transvenous pacemakers, coronary artery angioplasty procedures, alloplastic vascular grafts, and other non-valvular cardiovascular devices, including cardiac stents and vena cava filters. Few points about prophylaxis against prosthetic joint infection. Prosthetic joint replacements are also potentially susceptible to infection from transient bacteremia. When infected, prosthetic joints have a poor prognosis and frequently require removal with subsequent replacement. Is such similar to prophylaxis against infective endocarditis. Early versions of recommendations set forth by the American Academy of Orthopedic Surgeons involved a broad set of indications for antibiotic prophylaxis. In fact, recommendations from 2009 suggested use of antibiotics for all patients with prosthetic joints. However, subsequent revisions greatly narrowed the indications, and in 2016, the American Academy of Orthopedic Surgeons and American Dental Association published appropriate use criteria for prophylactic antibiotics for orthopedic implants. It recommends limiting use to recently placed prosthesis in patients with evidence of immunocompromise or poor glycemic control. This is due to the lack of the causal evidence of dental or oral surgical procedure directly leading to prosthesis infection, mainly due to very transient nature of the bacteremia during the intra and immediate post-operative period. The 2016 appropriate use criteria stress the continued need for sound independent judgment by the clinician. This includes close communication with the orthopedic surgeon as well as the patient. It is ultimately the dentist's decision and therefore responsibility to provide what he or she considers is the best care for the patient. The presence of an established odontogenic infection may present a different scenario compared with elective oral surgery in non-infected tissues. With established infections, the patient is exposed to a prolonged period of bacteremia. Therefore, it is crucial to aggressively manage the infection with immediate source control, incision and drainage, and also adjunctive antibiotic treatment. Culture and sensitivity testing have a greater importance compared with infections in patients without prosthetic joints, because if the prosthesis does get infected, antibiotics could be selected more accurately rather than simply empirically. Thank you. Wish you best of luck.